Welcome back to Doc Vatsa channel. Here we dive deep into NICE's guidelines on various health-related topics.
Mm.
Today we'll be exploring asthma, a condition that, frankly, has always seemed a bit of a mystery to me. I mean, we all know someone who has it,
hmm
but the more you hear about asthma, the more it feels like a catch-all term rather than a well-defined illness.
Right.
So I'm really curious to see what these BTSIGN and NICE guidelines have to say.
Yeah, it's true. Asthma is often oversimplified. It's not just about wheezing and shortness of breath. There's so much more to it.
Right.
And the UK's startlingly high asthma rates really highlight the need to understand this condition better.
That's right. The UK has one of the highest asthma rates globally,
hmm
which just makes you wonder, why is that? But before we get ahead of ourselves, let's go back to basics. What exactly is asthma, according to these guidelines?
Well, the guidelines do a good job of laying out the complexity of asthma. They describe it as a chronic respiratory condition characterized by airway inflammation and hyperresponsiveness. But they also emphasize its heterogeneity. Asthma isn't a single disease. It's more like a spectrum with different causes, severities, and even responses to treatment.
Okay, so it's not one size fits all.
Oh.
Does that mean there's also a wide range of triggers?
Absolutely. You have the usual suspects like allergens, smoke, and exercise, but then there's some surprising ones too.
Oh, really?
Did you know that in children, even laughter can be an asthma trigger? And in adults, certain medications can trigger symptoms? It really speaks to how individualized asthma can be.
Laughter. Wow. I would never have guessed that it makes you think twice about what might be setting off those symptoms, even for people who think they know their triggers.
Exactly. And that brings us back to the UK's high asthma prevalence. We're talking about 6.5% of adults in England. That's over 4.3 million people potentially being treated for asthma.
Wow.
And remember, that's just adults.
Yeah.
These numbers paint a pretty clear picture of how widespread this condition is.
It's almost like an epidemic, isn't it?
Yeah.
It's got to be more than just genetics or bad luck, right?
Yeah. Well, genetics definitely play a role, but they don't tell the whole story. The guidelines list a number of other risk factors, some of which are quite unexpected.
Okay, let's dive into those risk factors.
Yeah.
I'm ready for some surprises.
All right, well, how about this? Obesity is increasingly being recognized as a significant risk factor for asthma.
Really, what's the connection there?
Yeah.
I'd always assumed it was more about environmental factors or allergies.
It's complex, but researchers believe that increased inflammation in the body, which is often linked to obesity, might contribute to airway inflammation and hyperresponsiveness.
So it's not just about being overweight and making it harder to breathe. There's an actual physiological link.
Yeah.
That's fascinating. What other risk factors surprised you?
One that really stood out to me was social deprivation.
Mm.
It highlights the complex interplay between socioeconomic factors and health outcomes.
Right. It makes sense when you think about it. People facing social deprivation might have limited access to health care, poorer living conditions, and greater exposure to environmental pollutants, all of which could contribute to asthma development.
Exactly. And then there are workplace-specific triggers which often get overlooked. Imagine being a baker exposed to flour dust all day. That can be a major asthma trigger.
Yeah, it's a good reminder that our environment, both at home and at work, can have a huge impact on our respiratory health.
Absolutely. And speaking of long-term impacts, let's talk about prognosis. Is asthma a life sentence, or can you grow out of it?
That's a question I'm sure a lot of people are wondering about, especially parents of children with asthma.
It's not a simple answer. The earlier asthma develops, the better the potential prognosis. Many children who develop asthma before the age of 2 see their symptoms resolve by mid-childhood, but the severity of asthma in childhood is often a predictor of whether it will persist into adulthood.
So early intervention is key, but it's not a guaranteed cure. Are there studies that back this up?
There's a landmark study, the Melbourne Epidemiological Study of Childhood Asthma, which followed a group of children from 1964 all the way to 1999, tracking their asthma patterns into adulthood.
So what did they find?
They found that by age 42, only 40% of the participants were symptom-free. That means a significant number continued to experience asthma into adulthood, even if their symptoms had improved.
So while some people might grow out of it, for many, asthma is a lifelong condition that needs to be managed carefully, and that brings us to the question of complications we've talked about, asthma being more than just inconvenient. But how serious can it actually get?
It's important not to downplay the potential severity of asthma. In 2014 alone, over 1,200 people died from asthma in the UK globally. That number is a staggering 250,000 deaths annually.
Those numbers are a stark reminder that asthma can be fatal.
And Even if it doesn't result in death, asthma can have a significant impact on quality of life. We're talking about fatigue, missed work, or school limitations on activities, and in some cases, even psychological distress. It's not just about the physical symptoms, it's about the way asthma can affect every aspect of a person's life.
You've really painted a picture of how complex and multifaceted asthma truly is. It's clearly not something to be taken lightly.
Absolutely. But the good news is that with proper management, most people with asthma can live full and active lives.
That's encouraging to hear. So we've covered the basics of what asthma is, the concerning prevalence in the UK, the surprising range of risk factors, and the potential for long-term complications. But I'm really curious to learn more about how asthma is diagnosed and managed. Can we delve into those aspects in the next part of our deep dive?
Certainly, let's explore that further.
So let's shift gears and talk about diagnosing asthma. You mentioned earlier that it's not as simple as just listening for wheezing, what makes it so tricky.
Well, the guidelines really stress that diagnosing asthma is a clinical judgment, not something that hinges on a single test. It involves piecing together a puzzle of symptoms, patient history, and objective measurements.
Okay, so it's more nuanced than I realized. I remember as a kid, if you wheezed, you had asthma. At least that's what we all thought.
Right.
What are doctors looking for now?
Wheezing is definitely a key symptom, but it's not the only one. The guidelines highlight the importance of looking for a pattern of variable symptoms like coughing, breathlessness, and chest tightness. And these symptoms often have specific triggers like exercise, viral infections, cold air, or allergens.
Oh, yeah, we talked about some of those unusual triggers earlier, like laughter in children or certain medications. It seems like getting a detailed history from the patient is crucial.
Absolutely. Doctors need to be detectives asking detailed questions to uncover potential triggers and patterns in those symptoms. And family history can be a big clue, too. A personal or family history of atopic conditions like eczema or allergic rhinitis increases the likelihood of asthma.
So if you've got a family history of allergies, it's worth being extra vigilant about any respiratory symptoms you might be experiencing. But what about those objective tests you mentioned? What role do they play in diagnosis?
They provide more definitive evidence of airflow limitations, which are a hallmark of asthma spirometry, for example. Measures how much air you can inhale and exhale and how quickly you can do it.
Spirometry, that's the one where they make you blow as hard as you can into a tube, right?
That's the one that's offered to everyone over 5 years old who has asthma symptoms. And then there's the bronchodilator reversibility test, or BDR, which assesses how much your airways over up in response to medication. If your airways improve significantly after inhaling a bronchodilator, it supports the diagnosis of asthma.
So it's like a before and after snapshot of your lung function that's really clever. Are there any other tests doctors use?
Yes, there's also the fractional exhaled nitric oxide test, or FeNO for short.
That sounds high-tech.
It is pretty cool, actually. It measures the level of nitric oxide in your breath, which can be elevated in people with asthma. Think of it like a breathalyzer for inflammation in your lungs.
That's a great analogy, and what's impressive is how specific the NICE guidelines are about interpreting the results of these tests. It's not just about whether a test is positive or negative, it's about using the results to build a comprehensive picture of the patient's condition.
You're absolutely right, and the guidelines are also clear about considering alternative diagnoses if asthma is less likely.
That makes sense. What are some conditions that might be mistaken for asthma?
There are a surprising number of possibilities, conditions like bronchiectasis, COPD, heart failure. Even vocal cord dysfunction can present with symptoms that mimic asthma.
Wow, that's a lot to consider. It really underscores the need for a thorough evaluation by a qualified doctor.
Exactly. And once a diagnosis of asthma is made, the focus shifts to managing the condition effectively.
Okay, let's dive into that. What are the guiding principles of asthma management according to NICEs?
The overarching goal is asthma control. And when we talk about control, we're aiming for no daytime symptoms, no nighttime awakenings, no need for rescue medication, no asthma attacks, no limitations on activities, normal lung function, and minimal side effects from medication.
That's quite a list, basically. It's about living life to the fullest without asthma getting in the way.
Precisely. And achieving that level of control requires a multifaceted approach.
What does that approach involve? Where do you even begin?
The first step is understanding your individual asthma triggers and taking steps to avoid them. That might mean making changes to your home environment, like using dust mite covers or air purifiers, or it could involve avoiding certain activities or substances that, trigger your symptoms.
It's like taking away the fuel that feeds the fire, right? Get rid of the triggers and you reduce the likelihood of symptoms.
Exactly. The guidelines also stress the importance of self-management education and having a personalized asthma action plan.
That sounds empowering. What does that involve?
Patients need to understand their medications, know how to use their inhalers correctly, and have a plan in place for what to do when their symptoms flare up. It's about giving them the tools and knowledge to take control of their condition.
And of course, medication plays a vital role in managing asthma. What does the 9C's guidance recommend?
They recommend a stepwise approach to medication, starting with a short-acting beta-2 agonist, or SABA, which is your rescue inhaler, and then, depending on the individual's needs, adding controller medications like inhaled corticosteroids or ICS.
So it's about starting with the basics and then escalating treatment based on the severity and frequency of symptoms.
Right, and the guidelines provide very specific recommendations on when to step up or down treatment, always aiming for the lowest effective dose to minimize potential side effects.
It's all about personalized care, tailoring the treatment to the individual's needs. We've covered a lot of ground here. Diagnosis, the overall approach to management. But I'm keen to learn more about the specific medications and treatment strategies for asthma. Can we delve into those in the next part of our deep dive?
Absolutely, let's explore that further.
All right, let's get into the nitty-gritty of asthma medications. We touched on short-acting beta-2 agonists, or SABAs, which are used as rescue inhalers and inhaled corticosteroids, or ICS, for controller medications. Could you break those down a little further for me?
Of course, inhaled corticosteroids are really the foundation of asthma management that they work by reducing airway inflammation, which is at the root of those troublesome asthma
So
symptoms.
these aren't the same steroids athletes sometimes use, right?
No, not at all. These are delivered directly to the lungs in much lower doses, acting locally to tackle inflammation.
That makes sense. So ICS is the first line of defense.
Exactly. They're typically prescribed for anyone using their SABA 3 or more times a week, having symptoms that frequently, or waking up at night with asthma at least once a week.
What I find interesting is that the guidelines emphasize adjusting the ICS dose over time, aiming for the lowest effective dose. Why is that so important?
It's all about finding that sweet spot, controlling asthma effectively while minimizing the risk of side effects.
Right, makes sense.
But what happens when someone's asthma isn't well controlled, even on a low dose of ICS?
Good question. What are the options then?
That's when we might consider adding other medications. One option is a leukotriene receptor antagonist, or LTRA. It's a bit of a mouthful.
No, it is. So how do LTRAs work?
They're oral medications that block leukotrienes, which are inflammatory chemicals that contribute to asthma symptoms. Essentially, they tackle inflammation from a different angle than ICS.
So it's like a 1-2 punch to knock out that inflammation.
Yeah. You could say that. And if asthma is still not well controlled with ICS and an LTRA, the guidelines suggest adding a long-acting beta-2 agonist, or LABA.
So LABAs are like long-lasting versions of the rescue inhaler.
Exactly. They're taken daily to help keep the airways open and prevent symptoms.
It's incredible how many tools are available to manage asthma.
It really highlights the complexity of the condition, and the guidelines provide a clear roadmap for navigating these treatment options. Personalized care is key.
We've focused a lot on preventing symptoms, but what about when someone has an acute asthma attack? What does NICE recommend in those situations?
That's when your trusty SABA, that rescue inhaler, comes into play. The guidelines have specific recommendations for managing attacks depending on severity.
So there are different plans for mild, moderate, and severe attacks.
Absolutely. For mild cases, the SABA might be enough, but for more severe attacks, oral corticosteroids like prednisolone might be needed to quickly reduce inflammation, and of course, in the most serious cases, hospitalization may be necessary.
This raises an important question. How can people recognize the early signs of an attack and seek help promptly?
The guidelines stress the importance of self-monitoring and recognizing warning signs, like needing your SABA, more often worsening cough or wheeze trouble sleeping, or that feeling of tightness in your chest.
So it's all about being in tune with your body and noticing any shifts in your breathing.
Precisely. And if you see those warning signs, don't hesitate to contact your doctor or seek emergency care if needed.
It seems like knowledge is power when it comes to asthma. The more you understand your condition, the better equipped you are to manage it.
I couldn't agree more. Resources like the NICE guidelines, Asthma UK, and the British Lung Foundation are invaluable for individuals with asthma and their families.
This has been such an eye-opening deep dive. We've learned that asthma is a complex condition with a wide spectrum of severity and triggers, not to mention the concerningly high prevalence right here in the UK.
We've explored the intricacies of diagnosis, the crucial role of personalized management, and the stepwise approach to treatment outlined in the NICE guidelines.
I'm particularly struck by the emphasis on patient education and self-management.
Absolutely. It's all about empowering individuals to actively participate in their care, working alongside their healthcare team to achieve optimal asthma control.
So, As we wrap up our deep dive into asthma, what's the one key message you'd like our listeners to take away?
If you're living with asthma, remember you're not alone. There are effective treatments available, and with the right knowledge and support, you can live a full and active life.
Thank you for sharing your expertise with us today. This has been an incredibly insightful deep dive into asthma. And to our listeners, we encourage you to explore this topic further on the Doc Vatsa channel, and most importantly, consult with your healthcare provider to discuss your individual asthma management plan. Now that you have a deeper understanding of asthma, take that next step to learn about your personal risk and management options. After all, knowledge is power when it comes to your health.